of case histories of what, in retrospect, we would almost certainly call hysteria. Why did he insist that this was something different from hysteria? Well, they seemed to lack those emotional features. There was no undue apprehensiveness, but on the contrary, a cheerful tone of feeling and a hopefulness that is quite marvelous amidst so much helplessness and dependence, an entire absence of anything like hysterical spasm or general habit of either mind or body. It seems to me, he wrote, that many of the severer forms of nervous disturbance that follow the shock of railway accidents are of this nature. On the one side, there are cases of distinct nervous injury, on the other of malingering and sham, but between these two extremes, there are very many of morbid ideation. The man becomes really ill, but the region of illness is idea. This paper is important not only in itself, but because present in the audience at the British Medical Association when the paper was delivered in 1869 was the French neurologist Jean-Martin Charcot. And this painting of Charcot in one of his Tuesday lessons is a famous painting. In fact, Professor Srinivas has it in his office, and I was shown it when I was there on Thursday morning for a conference. It's a famous portrait showing Charcot surrounded by his acolytes, Babinski and Pierre-Marie and Paul Richet and so on, demonstrating this swooning female whose name is Blanche Whitman, an example of hysteria, demonstrating her pathology. Charcot is a key figure in the history of hysteria, and let's talk a little bit about his ideas. Charcot believed that hysteria was a disease of the nervous system. He believed it was hereditary. He believed it was progressive and degenerative. He believed it was governed by laws that he could define, much as he had defined the nature of other diseases of the nervous system, disseminated sclerosis, motor neuron disease. He was able to perform anatomico-clinical correlations on those diseases, define the course of the diseases, define the clinical picture of the diseases, and he believed he could do precisely the same thing with hysteria. He believed that hysteria might be precipitated by trauma, but that was really incidental. The trauma was nothing but an agent provocateur for what was basically a hereditary degenerative disease. Now, he knew from his autopsy studies that he was not going to find an anatomic lesion in hysteria the way he had in those other diseases, but he believed that there was what he called a dynamic lesion. Well, this is a less famous picture of Charcot. I hope it's probably less easy to see from where you are. This is a less famous picture, but it shows Charcot seated at a table while probably a different female patient is swooning in front of him. And again, he's surrounded by his acolytes. This is Charcot at work, not giving a clinical teaching demonstration, but actually seeing a patient. And his students left a description of how he worked. He sits down at a bare table and at once calls for the patient. The intern reads the history while the master listens attentively. Then there is a long silence, during which he looks and looks at the patient while drumming his fingers on the table. All the while Charcot says nothing. Finally, he orders the patient to make a special maneuver, makes him talk, asks for his reflexes to be tested, his sensory system to be explored, and again, a mysterious silence. We'll come back to what the significance of that way of working might be. And we'll now pass on to the last data point in the 19th century history of hysteria. And that is the work of Sigmund Freud. Freud, just as Charcot had gone to Reynolds' talk in 1869, So Freud went to work with Charcot in 1885, and he spent a number of months in Paris. Freud had trained as a neurologist in Vienna and went to Paris to continue his neurological, histological studies. He was interested in cutting the brain of children with cerebral palsy, for example. But it turned out that the facilities were inadequate for him to do that sort of work, and he ended up studying hysteria with Charcot. And this was transformational for his career, because from then on, his career took a different direction, and he studied hysteria. He abandoned his earlier interest in the brain. He abandoned his project to find a biological basis for psychology. I put project in quotes because he wrote a paper called Project for a Scientific Psychology, which he then put into a drawer and never published. He abandoned that area in favor of the study of hysteria. And in 1888, he wrote this paper. This is the so-called pre-psychoanalytic Freud. Usually people start dating psychoanalysis in 1895 when the studies on hysteria came out. In 1888, he wrote a paper at Charcot's direction on how to differentiate between organic and hysterical motor paralysis. And in the paper, he made some very astute points, no doubt learned at Charcot's knee, about how to do this through clinical examination. And then he considered the matter of a dynamic lesion, Charcot's idea about a dynamic lesion. And he rejected the idea that there was a dynamic lesion of the nervous system. His grounds for saying that were that if dynamic lesion means some sort of lesion localized in the nervous system that does not appear at post-mortem evaluation, if that were present, even if it were swelling, for example, that had disappeared by the time of autopsy, still the symptoms would respect the anatomy of the nervous system. And what he says was that I, on the contrary, meaning as against Charcot, assert that the lesion in hysterical paralyses must be completely independent of the anatomy of the nervous system, since in its paralyses and other manifestations, hysteria behaves as though anatomy did not exist or as though it had no knowledge of it. The lesion in hysterical paralysis will therefore be an alteration of the conception, the idea of the arm, for instance. This was not a conclusion that was easy for Freud to come to. And he wrote in 1895 in the Studies on Hysteria, I think quite genuinely, I think he meant it. And one of the reasons that I think that is that his French peer, Pierre Janet, wrote something very similar at about the same time based on his studies on hysteria. Freud wrote, like other neuropathologists, I was trained to employ local diagnoses and electroprognosis, and it still strikes me myself as strange that the case histories I write should read like short stories and that, as one might say, they lack the serious stamp of science. The fact is that local diagnosis and electrical reactions lead nowhere in the study of hysteria, whereas a detailed description of mental processes enables me to obtain at least some kind of insight into the course of that affection. So here we are in 1895, and the idea had become established that hysteria was a disease of ideas. Freud did one other thing, and that was he listened to his patients. And just to make this point visually, I want to contrast the famous Freudian couch with Charcot's table. Now, that description that I read you of Charcot's way of working didn't contain much conversation between Charcot and the patient. And in fact, Charcot was, as Freud wrote, un visuel, someone who looked and didn't listen. Freud listened. And this led to a different way of working with patients. Nowhere better captured than in this lovely remark of Henry Head's. Henry Head was a British neurologist who a few years later, Head was one of the physicians who took care of the novelist Virginia Woolf. And he wrote, "Diagnosis of the psychoneuroses is an individual investigation. They are not diseases, but morbid activities of a personality which demand to be understood." Well, I mentioned Hewlings-Jackson. Hewlings-Jackson was the great clinical observer of 19th century British neurology, and even more, the great theorist of studying the nervous system. And in his Croonian lectures in the early 1890s, he defined what he called the doctrine of concomitance. The doctrine I hold is, first, that states of consciousness are utterly different from nervous states. Secondly, that these two things occur together, that for every mental state there is a correlative nervous state. Third, that although the two things occur in parallelism, there is no interference of one with the other. A strict dualism. Now, this is quite an extraordinary statement, really, quite a startling, puzzling statement for a couple of reasons. Jackson was a clinical genius, but he was not a well-educated man. He was not philosophically sophisticated, and his philosophical thinking about this subject drew criticism even from his contemporaries. And the American neurologist Morton Prince said in what is a late 19th century example of extreme snark, "I cannot help suspecting that Hewlings-Jackson does not completely grasp the full meaning of this problem." But apart from lack of philosophical sophistication, there's another reason that Jackson is startling in this regard, and that is that no one, perhaps to the present day, has been more astute than Jackson at describing what he called the voluminous mental state of epilepsy. Jackson was brilliant at describing the mental concomitants of disease of the nervous system, the various odd mental experiences that go along with epilepsy, déjà vu and jamais vu and micropsia and macropsia and all sorts of odd things, and he described them brilliantly, and then he developed a theory that seemed to leave them out of the picture. What was he up to? Why did he want to do it that way? Well, let's go on with his lecture, Evolution and Dissolution of the Nervous System. Those who accept the doctrine of concomitance do not believe that volitions, ideas, and emotions produce movements or any other physical states. They would not say that an hysterical woman did not do this or that because she lacked will, or that a comatose patient did not move because he had lost consciousness. I do not try to show what is the nature of the relation between mental and nervous states. Jackson had what we would today call a research program. He wanted to develop a thoroughgoing biological understanding of the nervous system, and he didn't want people cheating by saying, well, he moved because he wanted to move. That was cheating. He wanted a physiological account of why people moved, a sensory motor account, and allowing mental phenomena in was, from Jackson's point of view in this research program, cheating. You had to do your physiological homework. Now, lest you think that this is a purely 19th century concern, if you take a look at what he says about a comatose patient here, and let's turn to the latest edition of the standard textbook on stupor and coma, Plum and Posner's textbook of stupor and coma, which is now in its 4th edition, just came out a couple of years ago. It is possible for a patient to be conscious yet not responsive to the examiner if, for example, the patient lacks sensory inputs, is paralyzed, or for psychological reasons decides not to respond. This is almost word for word what Jackson said you shouldn't be doing in studying the nervous system. And I think we can all agree that someone with selective mutism or someone with catatonia who doesn't respond to the examiner is different from someone in coma who doesn't respond to the examiner. But Jackson's research program was to say we need to develop a physiological account of those differences. So let me summarize. Where do things stand? Where are we by the end of the 19th century? Freud, Jackson. Well, at the beginning of the century, at the dawn of these specialties, psychiatrists took care of patients with severe mental disease in asylums. And often enough, these mental diseases were due to brain diseases, and those physicians knew it. At the same time, the neurologists were seeing patients with milder mental disorders under the rubrics of hysteria and neurasthenia who lacked evidence of structural brain disease and whose disorders were taken to be due to ideas and emotions. But by the beginning of the 20th century, the specialties had reversed field. They had switched so that in psychiatry, little attention was being paid to structural brain disease, and special attention was being paid to the dysfunction caused by ideas and emotions. And the neurologists, C. Jackson, had decided that patients with structural brain disease were the province of neurology, and they needed to pay little or no attention to ideas and emotions. Things had switched. Well, if I may be so bold as to put it this way, Charcot made two errors. One is that he was largely oblivious to the patient's psychology and psychological milieu. You know, it's now possible to see, looking back at it, that the reason those patients were swooning in front of him is that they were taught to swoon in front of him by the environment at the Salpêtrière where he was practicing. He was essentially totally oblivious to that. And it's very important to realize when you read Charcot, it's very important not to do so anachronistically, because Charcot would record, for example, that a young girl with hysteria had a father who was brutal to her. And it's very easy to imagine that he's telling us about traumatic experience, perhaps sexual abuse, and how the patient's experience led to her hysteria. But he's not. He's telling us about the patient's hereditary taint. Her father was a brute, and she has hysteria. It's inherited. He was largely oblivious to the psychological milieu. And to some extent, perhaps, we can say that this error, this obliviousness, was corrected by the work of Freud and Henry Head and others in that long tradition of actually listening to the patient. The other problem with Charcot's work is that he imagined a dynamic lesion, but he could not find one. And perhaps that's changed too. So this is an unreadable slide, I know. I've put it up merely to show that there now is a series, I think there are 9 studies in that slide, of the functional state of the brain in patients with hysteria based on contemporary functional neuroimaging with PET or functional magnetic resonance imaging. And I just want to tell you about one of these studies, one that's not included in that table because it came out at the same time as the article in the table. And this is a study from Patrick Viumier's group in Geneva. They had a single case, a woman with hysterical paralysis of her left arm. And they were able to show in this PET study, let's see, how can I do this? These red areas here.
There's the pointer there?
No, if I do it with this pointer, then people can see it on both screens. So let me do it this way. So I hope you can see this pointer moving here. These two red areas in the ventromedial prefrontal cortex and in the precuneus were the areas that were overactive in this woman when she attempted to move her paralyzed, hysterically paralyzed left hand. The authors point out that these two areas overlap to some extent with these green areas, the default mode network. What is the default mode network? Well, most studies of the functional state of the brain using imaging techniques have a strategy that goes like this. You put somebody in the scanner and then you say, do such and such a task, and then you figure out what areas light up when the subject performs that task, whatever it might be. The default mode network is the area that lights up when the patient isn't doing a task. It's the brain at rest. And it's now been widely studied and thought to represent the patient's, the subject's internal self-representation. It's when you're just drifting along thinking about whatever comes to mind, your default mode network lights up. And what they suggest is that this hysterical patient has overactivity of areas representing internal images, internal self-states that interfere with motor functioning. And they pursued that line of thought by analyzing connectivity, what hooks up with what functionally when the patient's trying to make these movements. And what you can see here is that there are these two areas, the precuneus here and the ventromedial prefrontal cortex here, are far more active, far more heavily interconnected with motor cortex than in comparison subjects. And the comparison subjects are healthy controls and especially interesting simulators. So this woman whom they studied, their single case, had hysteria. But they had some people fake paralysis of the left hand. And it turns out, according to this functional imaging study, that faking paralysis and having hysterical paralysis are quite different brain states. This is a result that would have been of great interest to my patient, a patient I saw just a couple of days before I left to come here. This is a young woman with pseudo-seizures, hysterical epilepsy, hysterical non-epilepsy. She has spells of shaking and unresponsiveness, which are not epileptic, but which are hysterical. And a few days before I saw her, she had had such a spell. Before she had it, she had the feeling that one might come on. She had called for emergency medical transport, been brought to an emergency room where she had the spell. And the emergency room physician had tried to wake her up by rubbing her sternum, leaving a bruise later, and yelling at her, "Stop it, stop that." And she was, when I saw her, devastated. How could he think I was faking it? How could he believe that of me? Well, she would have been, she was in fact, when I told her about this study, she would have been quite interested to know that faking it really is a different brain state from hysteria. So where do we stand? Is there a dynamic lesion that we can now define by contemporary brain imaging studies? We're not quite there yet. Perhaps we're getting there. A single case study by one group hardly is the end of the science of the subject. But perhaps we're getting there. We're not quite there yet. And where do we stand as far as Jackson's comment, I do not try to show what is the nature of the relation between mental and nervous states? Well, we're certainly not there yet either. But perhaps we're getting there also. Perhaps with the advent of contemporary cognitive and affective neuroscience, we're in a position where we don't have to be quite as modest as Jackson was, and we don't have to cling to the same research program quite so desperately. Perhaps we can genuinely look at the relations between mental and nervous states and try to understand them without losing track of the research program that Jackson set out for us. So let me conclude with another comment from that snarky article by Morton Prince, the American neurologist who said that Jackson appears not to have understood the problem at hand. He went on to say, if we can penetrate deeper still into the inner recesses of the nervous system and can extract the secret of the more intimate relation between the mind and the brain matter, we can scarcely doubt that much that is now obscure in the pathology of many neuroses and psychoses would become intelligible. And let's hope that we are getting there. Thank you for your attention.
Traditional in this oration that there's a short period of question and answer. I request Professor Trimble to join us on the dais, please. Yes, and Dr. E.S. Krishnamurthy. This was actually the invention of the family. They thought the oration ended rather bluntly, and everybody just went for the tea. So before we go and join people for the tea, there'll be this. Please keep your questions short, to the point, and announce what your name is, where you come from, and what your interests are. It'll be very helpful to us. So I'll now request the question and answer session briefly to start. Thank you.
Lecturers feel bad when no one asks questions. Lecturers feel bad when no one asks questions. It makes us feel that we didn't say anything interesting. So please feel free to ask some questions.
Sir, I'm Dr. Kamakshi. I'm a student of Professor Srinivas many years back. I have, it's a combination of a question and a situation and a patient. I'll just take about 2 minutes. When I was a student, I had a patient who was demented. When asked his age, he said he was 300 years old. I thought I had heard wrong. So I repeated the question, of course in Tamil language. He said 300 years, please keep it as 300 years. I thought that either I had gone mad or something had happened. Then I dubbed him as hysterical. It was the first year of my DM neurology. I said, this is possibly hysterical. Then my chief asked me to go back to the patient and examine. I did examine. And then when I made a neurological examination, I found that he was demented. And then he had pinpoint pupils, an Argyll-Robertson pupil. His ankle jerks were absent. And then the whole thing unraveled itself. It turned out to be a GPI along with a Tabes component also. He also said he was a prince, incidentally. So it is a combination of a taboparesis. Now, in this era, taboparesis has almost become extinct. I have not seen, after those 30 years, another case of taboparesis. Not even a GPI. So I was just wanting to share this with you and ask you whether you see cases of GPI.
Well, First, as far as the extinction of neurosyphilis, sadly, it is far from extinct, and the AIDS epidemic has also led to a recrudescence of syphilis, and it's generally felt that syphilis is harder to treat in the presence of HIV infection. I can't say I have a large personal experience of general paresis of the insane, but it is certainly a disorder that still needs to be considered in the differential diagnosis of dementia today. Second, let me comment about the Ganser state. Ganser was a German physician who described patients who give approximate answers. So to simple questions that anyone would know the answer to, how many legs does a dog have? They say 5. And the discussion has raged, that's probably putting it a little strongly, since Ganser's description about whether this is an organic state or an hysterical state. And if you look back at Ganser's description, at least 2 of his original 3 patients pretty clearly had organic disease. So the symptom of approximate answers is a symptom that, 300 isn't that close to the actual age of your patient, I'm sure, but the idea that someone would not be able to give an answer to a simple question that they probably did know the answer to, that symptom often has an organic basis, although sometimes perhaps not. Michael, do you have a?
Thank you.
I'm Dr. Rabindranath, psychiatrist. There have been many reports and studies that hysterical patients followed over a period of time, 10 years, 15 years, do show some evidence of neurological problems. Do you like to comment on that and what is the experience?
Fortunately, there's now a very considerable body of work on that issue. The classical paper by Slater on the misdiagnosis of hysteria is a paper that Professor Trimble and I don't completely see eye to eye about, but he reported 30-odd% rate of missed neurological diagnosis. But John Stone in Edinburgh and his colleagues have looked at this very carefully and done their own studies. And it's clear that even if Slater was right in his own patient material 40-odd years ago, 45 years ago, this is no longer the case. And the actual current rate of misdiagnosis of hysteria, assuming that the diagnosis is made on appropriate grounds, is more like 3 or 4%, well within the range of the accuracy of diagnosis of myocardial infarction or other medical conditions. Now that said, there's another aspect of this which has not been the subject of recent clinical attention, I think unfortunately so, and that is one of the positive things about Slater's article in the 60s was that he made it clear that the behaviors we call hysterical, the emotional state that we call hysterical, the relationship with the doctor that we call hysterical, these things may all be the result of organic brain disease. The patients may have organic personality change that leads to these kinds of behaviors. And in the 60s and 70s, there were a number of studies looking to see how many patients who genuinely had hysteria actually had, if I can put it this way, organic hysteria, that is hysteria due to personality deterioration related to genuine brain disease. And those studies have unfortunately disappeared from the literature. So I don't think we have much information about how often patients produce hysterical manifestations because they have personality change due to brain disease.
Calcutta. Now, you have already touched on it. I was going to ask about Slater's work. Now, you said now the history has been revised to some extent. I suppose this is because of our armamentarium of investigations, which has made it easier to detect organic states much earlier than it used to be some 60 years ago. Now, still, in the earlier stages, as you said, the subtler forms of organic condition can present as so-called functional, but that is only the manifestation of the same organic state, but the actual structural neurodeficit has not yet come. That's what I was questioning, the reason for misdiagnosis. Not that the physicians failed or made wrong diagnosis, but that it was very early when the neurological structural process could not have been detected. But it is the same process.
As to the role of contemporary diagnostic technology in the improvement of diagnostic accuracy, I'm sure that's a factor, but I doubt that it's the only factor. And much of the improvement actually took place before the advent of MRI, for example. I'd like to make one other comment about this general area of misdiagnosis, because, again, this is what I would consider a strength of the Slater paper. There is a risk of missed organic diagnosis, missed neurological diagnosis in patients who, for one reason or another, are taken to be hysterical. And that's a significant problem, and we all need to be attentive and thorough and open-minded. But there's a risk on the other side, too. And the risk on the other side is that patients will be taken to have organic disease when the evidence for it is slight, and their emotional disorder, their psychiatric disorder, will be ignored by treating non-psychiatrists. And this is a problem that's associated with considerable morbidity and unhappiness on the part of patients whose lives are blighted by the presence of the emotional disorder, which is being ignored because everybody's treating them for this or that or the other thing, which they actually don't have.
My name is Radhika. I'm not a doctor. I just want to know, is biologically a woman more prone to hysteria than man?
Michael? Probably it would be fairest to say that the disorder takes different forms in women than in men. Yes, presentation with hysterical paralysis, for example, or pseudoseizures is more common in women than in men. The interesting genetic finding is that in the families in which hysteria runs in the women, antisocial personality disorder runs in the men. So whatever the fundamental defect is, whatever the personality defect, whatever the deficit in biological makeup is, it seems to take a different form in women from the form it takes in men.
I am Dr. Chokalingam. I appreciate Srinivas for his excellent way of opening up the orations for questions. There's a recent trend I appreciate. I'm a cardiologist basically. I saw 3 days ago a doctor student called me, 19-year-old engineering student having a severe chest pain, palpitation, breathing difficulty. He witnessed his father of 52 years. He lost his father about 3 months ago. The doctor was reluctant whether it's a functional or organic. This happened at 3 a.m. I told him, please send it, don't take any risk. When I saw him at 3:15 a.m., I saw him had a massive heart attack. Why I'm telling this point is, no question of taking certain symptoms as a functional, but you should not miss the real killing disease. The psychological trauma, the mental tension, as a third-year engineering student, if I had not taken the risk of, precaution of seeing, you would have lost him. Another comment and question is, the person who had an enormous emotional upset gets the heart attack. After the heart attack, he becomes cardiac neurotic. So it becomes a vicious cycle. The neurologist, psychiatrist, cardiologist must play a greatest role to break the cycle of it. And question to the presenter, hysteria, is it curable? How often you have get rid of complete cure for them? How a girl of 19 or 15 years, never exposed to symptoms of diseases, but able to mimic certain aspects of the diseases, how is it possible for her to say either paralysis or fits, never witnessed in her lifetime? How do you explain that manifestation of it? Thank you.
Well, thanks for your comments. Is it curable? Well, like every other disease in medicine that I can think of, it comes in mild, moderate, and severe forms. So, there are people with relatively mild disorders who do quite well. There are patients, on the other hand, who are extremely chronic despite everybody's best efforts. So, people can get better. Some people can get pretty much all better, but a lot of patients will be chronically impaired.
As a layperson, I would just like to ask whether it is possible to speak to a person in coma and revive him from coma back to this thing by merely speaking and continuing to inspire him and speak to him. Is it possible? Because it has happened in my family. The father was a doctor, the son is a doctor. The father went into coma after he had severe pneumonia. This is in the United States, this happened. And the son, being a doctor, was talking to him constantly, telling him of progress, and though he was in a ventilator, he was in coma. For 15 days, he continued to talk to him, and of course the treatment was going on. And one day, suddenly he came back out of coma, and he was on the way to recovery, and he's okay now.
So the question is whether people can recover when others had given up on them.
Yes.
Yes. Well, this is pretty far from my expertise, and I don't want to say too much about it because I'd end up being wrong and misleading. But it certainly is an area of considerable interest, especially because, as you may know, as others may know, there have recently been a number of cases in whom, a number of patients in whom, despite the absence of behavioral evidence of brain function, there was functional neuroimaging evidence of brain function, so that, for example, Michael, may know more about this than I do, but it was, for example, you say to the person who's lying there in coma, do you like tennis? And nothing happens. And you say, well, this person's in coma. And you attach the person to a brain scanner, and you say, imagine yourself playing tennis, and the tennis playing parts of the brain light up. And that kind of finding leads people to enormous excitement about the possibility of patients who appear to be comatose or minimally conscious eventually waking up. Unfortunately, most of the time, those hopes on the parts of families will be disappointed. What the percentages are, this is outside my expertise. Exactly how to approach the problem, it's outside of my expertise. But there probably are some people who can now or soon be identified to be more alive than we think. But for the most part, when they look bad, they're bad, and families will end up being disappointed if they get their hopes up too high.
Dr. Sunil Narayan from Jipmer. Exactly 10 days from now, Professor Krishnamurthy Srinivas has been a visiting professor to our institution. And I had the opportunity to show to him a patient around 55 years old, who was the son-in-law of one of the founder politicians of Pondicherry, a person with chronic smoking and diabetes, who had, I'm sure Professor Srinivas will be remembering him, he had a left lower limb monoparesis, and there was some white matter, demyelination changes, small vessel disease. And this problem of left lower limb monoparesis clinically was something looking like a catatonia or paratonia or some kind of apraxia of the left lower limb. Classical upper motor neuron signs were not there, but though there were bilateral soft pyramidal signs, upgoing plantar, etc. So Professor Srinivas had a long talk with him and advised to be seen by the medical social worker and also to continue with the physiotherapy. And I would like to inform Professor Srinivas that the next day after he had left, this man had shown very considerable improvement, and he is now walked, and in fact the day before I came over here, he got discharged also. So the effect of proper counseling and the psychological changes that imparts into the patient, especially by a person develops a lot more, definitely he had developed a lot more trust in Professor Srinivas than in myself, does do wonders to some of these patients. Thank you.
I'm Gopal from Anna University, professor at Anna University, Computer Science. With the permission of Professor Krishnamurthy Srinivas and Dr. E.S. Krishnamurthy, I would request you to enlighten me on, is there a specialization which is based on psychology of programming? I'm a computer science professor. We tend to abstract things. The number of microphones in this room is just an array. It is just something which is mapped completely out of the real world, and we program based on that. There's a book by Gerald Weinberg with the title Psychology of Programming, and would you think that we need to explore this specially, separately?
This is even farther outside any expertise that I have. I'm sorry, I just don't know the answer to your question.
Sir, hello, I'm Satyendra. Here. I'm Satyendra, I'm a polyglot. I'm a student of philosophy and literature. Near Bangalore, about 70 kilometers, there is a village where about some 100 to 200 patients will come. I mean, ordinary village people with lot of hysteria. And there is a Muslim priest, you know. He cures everybody. I have seen, we have made a film with a French psychiatrist. I have seen people behaving so rough, you know, banging their head, all kind of things, but no medical help. But in few days, they believe they recovered. I was there. Many people recovered. People come from Bombay, Delhi, and people who are not cured in the biggest hospitals were cured there. How do you explain this phenomenon?
See, medicine is largely a cultural subject, and therefore what happens in this country and what you do for patients here may not be relevant, for example, from where Professor O.C. comes from. So what you're saying we've seen as doctors, but to give an explanation is going to be very difficult.
The human beings are everybody same, sir, whether in America or here.
One of the problems is you need a follow-up in medicine. In other words, the person should come back 5 years later and said he's very much better and he's okay. But follow-up in India is care of the footpath. People don't come back, and people don't come back for follow-up, and find it very difficult.
Thank you.
One more question and we close.
My name is Dr. Praveen. I'm from Cochin. What is the current understanding of the mechanism of suggestibility in pseudo-seizures? The fMRI study which you showed, was it done during the interictal period when a suggestion was given, or was it done during the ictus?
Well, the fMRI data I showed were from a single patient with continuous left arm paralysis. So it was during the ictus, so to speak, or it was during the presence of the symptom. The mechanism of suggestibility. Suggestibility is highly heritable. And to the best of my understanding, it is not highly correlated with other personality traits. So I don't know what the mechanism is, but it seems to be a human trait that, like many other traits, varies within the population. Some people have a lot of it, some people have a little of it, and it's under some genetic control, considerable genetic control.
So is it possible that these pseudo-seizures are more common in that group of personalities who are more suggestible?
Well, you're raising a, let me slightly shift the ground of your question. Suppose we had a patient or a subject who had been hypnotized into left-hand paralysis. So you've got healthy controls moving their left hand normally. You've got simulators who are faking left-hand paralysis. You've got hysterical left-hand paralysis. And then a fourth group would be patients who are hypnotized into you can't move your left arm. What would that group look like? And I can tell you that the article from which I showed that fMRI, which came out in the latter part of 2009, has reference to the same group's work on hypnosis, quote, in press. So we'll both know soon.
Thank you very much.
It is now my pleasant duty to propose a vote of thanks. Let us give a standing ovation to the Srinivasan family. Thank you. And now an ovation for our orator, Professor O.C. Sir Robert Hutchison said, 2 qualities are necessary for the success of a doctor. The first is good health, and the second is good luck. And I certainly have been endowed with a lot of good luck for knowing this family, having moved with them very closely for many, many years. And without their support, I don't think this program could ever have got started or could have gone on for 30 years. So it's really a great pleasure for me to propose a vote of thanks to all the family members. Secondly, I want to thank Mr. Venu Srinivasan's assistants, colleagues, all of them, Mr. Lakshmanan, Executive Director, the doctors in the center who are very efficient, and they even got a nursing supervisor with whom I've had a long chat. And then, of course, I've been nagging Bala, their public relations officer, before all the various things, because neurologists are more obsessional than neuropsychiatrists. So thank you very much for Venu's colleagues and so on who have helped us. Then we wish to thank the various people who have helped us behind the scenes in constructing this program. And I shouldn't forget our own department staff members and all of those who have participated. And finally, I want to thank the Park Sheraton Hotel for having this year organized a separate place for us to run this workshop. So with those words, ladies and gentlemen, we conclude this program. But before I conclude, I want the Srinivasan family to join us for the traditional photograph with the orator, Professor Trimble, etc. Thank you.